Good morning, good afternoon, and good evening. Thank you for joining us today for a discussion on preventing unintended pregnancies in the context of COVID-19, hosted by the Wilson Center's Maternal Health Initiative and UNFPA. I'm Sarah Barnes, and I direct the Maternal Health Initiative at the Woodrow Wilson International Center for Scholars. The Wilson Center is a DC-based think tank that brings fresh thinking and deep expertise to the most pressing policy challenges we face today. We work to create a global dialogue of ideas that Congress, the administration, and the international policy and health community can act on. At the Maternal Health Initiative, or MHI, we focus on ending preventable maternal deaths and navigate gender-related global health issues. The current pandemic is straining human resources, disrupting supply chains and service delivery, and negatively impacting service seeking among women and girls in countries across the globe. However, it is disproportionately affecting women and girls in low and middle income countries. School closures, limited access to comprehensive sexuality education and contraception, and risk of violence against women and girls put them at a higher risk for unintended pregnancies. The discussion today on strategies to prevent and address unintended pregnancies in the wake of COVID-19 will focus on current country-level strategies and best practices. We have an exceptional set of panelists here today from the DRC, Nepal, and Argentina to share their expertise and country perspectives. We are also delighted to have Beth Sully here from Guttmacher Institute to give opening remarks to set the global stage and share some data and trends on preventing unintended pregnancies in the context of COVID-19. I want to just take a moment to thank all of our panelists today, as well as our two Spanish translators, for taking the time to be here today and discuss these really important issues. I would also like to thank UNFPA for making this event possible, as well as my colleagues at the Wilson Center. The Wilson Center and UNFPA have been partnering to advance the global maternal health dialogue for 12 years. And in those 12 years, it has been an honor and a pleasure working with dozens of incredible UNFPA team members. Our moderator today, Annika Knutson, is one of those exceptional team members that I'm grateful to have worked with during the past several years. Today is particularly significant as it will be her final time participating in an event under the Wilson Center UNFPA partnership, as she is set to retire in 2022. While we will be sad to see her leave her current role with UNFPA, I know our paths will cross again. So thank you, Annika, for all of your work to support both the Maternal Health Initiative and the Greater Wilson Center as we continue to tackle issues of maternal health and gender inequality. And best of luck to you as you head into retirement. And for those of you who don't know her, Annika is Chief of the Sexual and Reproductive Health Branch at the United Nations Population Fund, or UNFPA. She became a teacher in midwifery before earning her doctorate in healthcare pedagogics. Prior, she was a midwife advisor for UNFPA in Bangladesh and worked at the Swedish International Development Agency for a decade. Before I turn things over to Annika, just a few housekeeping items. We will have time at the end of the discussion for an audience-led Q&A. So please send your questions to mhi@wilsoncenter.org, and we will get those questions to our panel. Do send us in some questions so we can be sure to address the things that you think are most important. Again, that's mhi@wilsoncenter.org. You can also follow the discussion on Twitter @Wilson_MHI using the hashtags MHDialogue and COVID-19 and SRH. So without further ado, and with great thanks, I turn things over to you, Annika.
Thank you so much, Sarah, and thank you for those kind words. It's really been a pleasure, and I'm sure we will continue to work together. So I just wanted to say how happy I am to moderate this session today. I think that this topic, the increasing unintended pregnancies that we know, and the situation of young women, older women, everyone, every person in the COVID pandemic, has really exacerbated the vulnerabilities that we know exists already. And I think that events like this can really heighten the urgency that we know needs to be heightened, but also let us discuss solutions to these problems and really hear how people in different parts of the world have come to really innovative and really very dynamic solutions. So without further ado, I just want to say that UNFPA is really, really proud to be a part of this partnership. And it is very much in line with our strategic plan to look at how we can have a very comprehensive outlook on sexual and reproductive health and rights, and really make sure that young people and young girls in particular can have their full potential fulfilled. So as Sarah mentioned, we have an opening speaker, and I'm really happy to have Beth Sully here, who's a well-renowned and very inspiring speaker. She's a senior research scientist at the Guttmacher Institute, where her research focuses on sexual and reproductive health, including abortion measurement, adolescent health, family planning, and the impact and cost of sexual and reproductive health services. Beth, or Dr. Sully, maybe I should say, earned her MA in Public Affairs and her PhD in Public Affairs and Demography from the Princeton School of Public and International Affairs and the Office of Population Research. So Beth, really happy to have you here, and over to you for your opening presentation. Thank you.
Thank you so much. I'm happy to be here with all of you, and I'm just going to share my screen because I'm going to start talking today about some data and trends. And the only way to do that is with slides when you're a researcher. All right, so let me get started. There we go. So I'm going to present key findings today from two new and critically important bodies of evidence that's really going to try to set the stage for the roundtable conversation that's going to follow from colleagues who are going to then provide sort of the in-depth insights from the country perspective and success stories and really lessons learned moving forward. So the two studies that I'm going to draw from, the first are new estimates of unintended pregnancy and abortion worldwide. These are global data that I'm going to present, but there's also regional and sub-regional data available. And it would be amiss not to plug that there'll be country level estimates of unintended pregnancy and abortion being released in early 2022. The second study that I'm going to draw from is Adding It Up, which estimates the need for, cost, and impact of sexual and reproductive health care in 132 low and middle income countries. Together, these studies show that unintended pregnancies were occurring prior to COVID and what impacts we could see by making smart and cost savings investments to ensure that the progress that we have obtained is not lost during this pandemic. There are three overarching points from the worldwide abortion study evidence that I want to highlight. First, unintended pregnancy and abortion are reproductive health experiences that are shared by tens of millions of people around the world, irrespective of their personal status or their circumstances. What differs are the obstacles that they face in obtaining these services or having these experiences. These are legal, social, economic, and other obstacles. The second key point is that unintended pregnancy and abortion occur where abortion is broadly legal and where abortion is restricted. And the third is that in developing countries, abortions tend to be unsafe and health systems in those countries lack the capacity to provide essential abortion services. First, I want to situate the evidence in the historical trends and the progress that we have achieved thus far. This plot shows the unintended pregnancy rate in blue and the abortion rate in green for 5-year periods over 30 years from 1990 to 2019. And the shaded gray areas are the uncertainty intervals around these estimates. For unintended pregnancy, the blue line, we see that it has declined from the 1990s, but the steps were steepest in the early years from 1990 to 2004. For abortion, we see that there was a similar decline early on from 1990 to 2004, but the rates began to increase again so that by 2015 to 2019, the abortion rate was similar to what it was in 1990 to 94. This increase in the abortion rate in recent years can be attributed to the percent of unintended pregnancies that are ending in abortion increasing since 2005. And this may reflect an increased motivation for people to avoid an unplanned birth, as well as increasing access to abortion. For the most recent time period, these rates mean that worldwide, there are 121 million unintended pregnancies and 73 million abortions that have occurred each year from 2015 to 2019. That means that 48% of all pregnancies were unintended, and 61% of unintended pregnancies ended in abortion. Let's turn now to the adding it up evidence that shows the need for, impact, and cost of providing a comprehensive set of services. More than 90 health interventions, including modern contraception, pregnancy-related and newborn care, and STI treatment. These estimates represent 1.6 billion women of reproductive age in 132 low and middle income countries, and they show the immense need for these services before the pandemic hit. Access to and use of effective methods of contraception to prevent pregnancy have been increasing over time. We know this from estimates from the United Nations Population Division. Nonetheless, despite this increase in modern contraceptive use, the need remains large today. More than half of women of reproductive age in low and middle income countries, which is 923 million women, want to avoid a pregnancy. Among these women wanting to avoid a pregnancy, 1 in 4, or 218 million women, have an unmet need for modern contraceptive methods. That means they are either not using any method of contraception, which is 148 million women, or they are using a traditional method, 70 million women. And the consequence of this is unintended pregnancy. The vast majority of unintended pregnancies, 77% of them, are to women who have an unmet need for modern contraceptive methods. So what is the potential impact of fulfilling current needs for these essential services? If all unmet need for modern contraception and pregnancy-related care were met in low and middle income countries, there would be approximately a 2/3 decline in unintended pregnancies, going from the current estimate of 111 million to 35 million per year, a 2/3 decline in unsafe abortion from 35 million to 10 million, and a 2/3 decline in maternal deaths from 299,000 to 113,000. The impact of investing in these services would have immense benefits for women and their families and communities. The interventions that make up the package of care included in the adding it up analysis have proven feasible to implement in diverse settings around the world. And importantly, investing in them can lead to cost savings. And that information is important now more than ever, given the COVID pandemic and the constraints on resources. According to our latest analysis, for every $1 spent on contraceptive services beyond the current levels of care, we would end up saving $3 in the cost of maternal, newborn, and abortion care. Why? Investments in contraception reduce unintended pregnancies, and that ends up saving the health system's costs. We know that governments are making tough decisions right now on their spending priorities. Fortunately, the adding it up lesson that packaging SRH services can lead to savings follows through even to smaller bundles of services. When you invest in safe abortion care, you save money in post-abortion care costs. So across the whole, a package of sexual and reproductive health services is a smart and cost savings investment. It's also a smart investment for adolescents. A package of care that would meet all adolescent women's needs for modern contraception, pregnancy-related and newborn care would cost just $1 per capita per year in low and middle income countries. And that's only 59 cents more per capita compared to current costs. So building back from this horrific pandemic means using data to ensure that sexual and reproductive health and rights are a priority in rebuilding and improving healthcare systems, and to continue to spotlight the need to address inequities. The Institute has published 132 country profiles highlighting country-specific estimates for the need for, impact, and cost of fully investing in these services. In other words, it's a mini investment case at the country level, including for adolescents. In nearly all countries, every dollar spent on contraceptive services beyond the current level, that we would see a cost savings in maternal, newborn, and abortion care. In grappling with the fallout from the COVID-19 pandemic, many countries are working on how to provide affordable, high-quality care to all individuals who need it, including taking steps to shore up access to supplies and medicines, promote telehealth options, increase fundings to global programs to expand access to sexual and reproductive health care. All of these actions are essential to ensure that the progress that I have talked about today is maintained and that we continue to work to address reducing unintended pregnancies globally so that this pandemic doesn't reverse the gains that we've made over the last 20 years. I just want to conclude by thanking our generous funders that have supported all of the different evidence that I've presented today, and thank you for the opportunity to share it with you.
Thank you so much, Beth. And I think there was a lot, there is really a wealth of information in your presentation, but I'm sure that we will sort of address it through our panelists' interventions and how they see what you are talking about at a global level, how that really materializes on the ground. So what we'll do now is move into the panel discussion, and I would like to introduce first our panelists and also remind everyone that please continue now to Beth and to all the panelists to put your questions in the web address that was shared, mhi@wilsoncenter.org. And please indicate your name, title, and affiliation with your submitted question. I will be reminding you on and off of this. So we have an amazing panel here today, and I'm really happy to introduce first Lirisha Tuladar. Lirisha Tuladar is from Nepal. She's a young SRHR advocate working in SRHR at the local, national, and international levels for over 5 years. She's the current secretary of the Youth Coalition in Sexual and Reproductive Rights, and she's also the founder of Unfolding SRHR, a digital platform where she's doing local initiatives with digital innovations for the young people of Nepal, including safe abortion. And I know that you will be hearing some very exciting examples from her. We also have Jean-Claude Mulunda. Dr. Mulunda is the current country director for IPAS in the Democratic Republic of the Congo, DRC. He previously managed sexual and reproductive health with the United Nations High Commissioner for Refugees and International Planned Parenthood, DRC, and is a Planned Parenthood DRC affiliate. Last but not least, we are very proud to have Ms. Valeria Isla. Valeria Isla is the Director of Sexual and Reproductive Health in the Ministry of Health in Argentina, and has some really exciting both current information on the status in Argentina, but also the bold moves that Argentina did on the issue of abortion recently. So without further ado, I would like to have a little warm-up question to you. So why is this event so important to you and the work you do? And I would like to start with Lirisha. Lirisha, are you?
Yes. So hello and namaste everyone. I am Lirisha from Nepal, and I'm so excited to be in this platform and sharing this platform with all of you guys, and representing Nepal is a huge opportunity for me, as well as it is also an opportunity for Nepal itself that our youth is representing and also being able to participate in this very good program. And I'd say that this program means a lot to me as a youth myself, as a woman, as a girl from Nepal, where this topic is not so discussed as well. Not just this topic, but the entire topic of sexual and reproductive health. It's still in the initiative phase, and it's very stigmatic topic, and we are not allowed, let's say, and we are restricted to talk about this freely. And this platform would be a very major breakout for me, I'd say, or breakout for our entire youths that I'm representing from Nepal, to highlight about one of the most significant issues that is underlying beneath the veneers and beneath the curtains of the society. So there is this intergenerational gap that has been causing the youths and the young people to not discuss about this topic, and this topic being hidden behind the curtains. So I think this would be a platform for me to also break that stigma and then come forth and bring out the issues that are most important to be addressed, and reduce the information gap. So myself, as said in the introduction, I have started my own digital platform called Unfolding SRHR. So I've been trying my very best to bring out new innovative ideas, especially during this COVID. I started this platform, and from there, just digitally, I've been trying to bring out the ideas, especially related targeting to Nepal on the SRHR issues through the social media sites like Facebook, Instagram, and any digital platform. So in that way, I'm trying my best as well. And this would also be a very good head up start for me to continue my journey. So thank you, everyone.
Thank you. And we'll come back to all of that exciting work that you're doing. So I turn now to Jean-Claude. Why is this so important for you to be here and be part of this event? And why is the event itself important, you think?
Yeah. Thank you so much. And hi, everyone. Good morning, good afternoon from Kinshasa in DRC. I'm so happy to be here and to share about what we are doing here with all the stakeholders in the country. I think this event is really important for us. I can share like 3 reasons why I think that this event is really important. The first reason for me is that this event provide has a unique opportunity of for learning and sharing about the experience on the ground, from what we are doing, but also learning from other countries, our region in the world. You know, we are not living the COVID situation the same way. It's a little different from region to another. So it's an important opportunity for what we are doing, but also to learn from other countries and the region. The second reason for me is that this event is really important because it's also an opportunity for us to recognize and encourage champions, all those who are involved in advocacy, in service delivery, in social support, to ensure that women and girls have access to the SRH services, especially during the COVID. And the last one is to advocate. You know, it's important for us to continue advocate for women and for girls. And this event is also the way for us to send our message to decision makers, to let them know that behind the vaccination and the social distancing, other created or worseness problems, need the attention. Thank you.
Thank you so much. And I think also there we have a lot to come back to. So now over with my first question to Valeria. Why is this so important to you and to the work you do?
Muchas gracias.
Thank you very much. For Argentina, for the Ministry of Health, it's very important with colleagues that have such a wealth of experiences, such different experience. And of course, with the Wilson Center, with the UNFPA, that for us in the area of sexual and reproductive health and the right to abortion has played a fundamental role. They're part of our advisory committee, and in Argentina have done very significant work, such as Milena, which is a study prior to the pandemic on the economic impact of unintended pregnancies in youth. And this has been replicated in other parts of Latin America and is a great contribution to our country. I'd also like to highlight the importance of having an impact and continue giving visibility to the priority we should have in sexual and reproductive health, be the contraceptive methods with different methods, long extended duration for youth, and also voluntary and legal termination of pregnancy. These are issues that we all know, those of us here and the organizations and activists too, that has been very difficult to maintain on the agenda in these years of COVID. As our colleague Jean-Claude said, apart from COVID, in addition to recognizing this as an essential service, we had to support with strategic partnerships the issue that sexual and reproductive health and the rights for youth and people with uh, pregnancy issues was a priority. It was not beyond the pandemic agenda. It was inherent. It's within that agenda of priorities. On the other hand, it's also important to share experiences of what happened to us and perspective for girls and youth subject to sexual and reproductive violence. With Argentina, with the worsening of these situations. So I'm very happy to listen to the exchange that we will have here and share also our experience to continue with the link and strengthen the network and expand the cooperation networks in this field. Thank you.
Thank you. And we have also Beth here, but you have done your introduction. So maybe if I may, I will jump this question and come back to you, because you have really made a very important, statement on what the situation is. And of course, we see that there has been progress, but we also see that it's too slow. And we're really concerned now that what will happen, we do not want to lose the gains we've made, of course, due to COVID. So I'm now turning back to you, Larisha, because I would really like to hear from you. How has the pandemic affected the rates of unintended pregnancy in your country? But also, what kind of innovative approaches and adaptations have been used to reduce it and reduce also unsafe abortions, especially among the young population? So over to you, Larisha.
Thank you so much, Annika, for the question. This COVID-19 surely has affected all of us equally, all of the countries, and especially in Nepal, which is also a developing country, and it is not as much developed as all the UK, European countries that we have. And as I mentioned before in my opening remarks, that this topic of the SRHR itself, especially about this unintended pregnancy, abortion, and especially the woman-related issues, they are not discussed freely in the society itself. It is almost taken as a taboo topic to be discussed about. So especially when I'm also working in this area of health, and I got to know the information that especially this unintended pregnancy had increased a lot during this time, because most of them were unaware about this contraceptive, how they could get it, and especially this COVID being initiating the lockdowns, all the health institutions were also closed as well. So because of that, it was a huge problem for even the individuals who wanted to go and seek the contraceptives. They could not seek the contraceptives, and they had the problems in that way. And also another reason was that most of the male members of our country go abroad for working. And during this COVID, when it was a really fearful situation and they had no work at all in abroad, they were taken out from their jobs, they all returned to Nepal, to their wives and to their family. And during that time, because of the lockdown, they stayed with their family, and then they had the sexual contact, and the unintended pregnancy also rates also increased a lot in that way. And especially if I have to talk about the youths, during this COVID, they also had a lot of dropouts, due to which they could not get the information about what is abortion. Our curriculum itself is not comprehensive, and it doesn't have a lot of element about this abortions and unintended pregnancy. So there is a information gap itself in the school curriculum, but also adding to it, this COVID was not able to reach them to the proper sexuality education. Even the other organizations, and even I I myself was involved in giving comprehensive sexuality education in an extracurricular activities to the youths and young adolescents. But because of this COVID, even we could not reach out to the places and we could not reach out to the needed population. So that's why we had a lot of information gap and more unintended pregnancy increased. And one more cross-cutting issue that this COVID had brought in this issue of unintended pregnancy was the gender-based violence that was prevailing in the societies. So most of them were confined to their homes, but still there were domestic violence and there were the gender-based violence like rape. The rape cases had increased so much and it had brought so much of the unintended pregnancy. And even the one who were raped, they could not seek the health services, they could not go for the abortion services. So because of that, the rate had of a, that the rates had been increased a lot. But this was just the negative impacts or the negative effects that the COVID had brought. But also looking positively, we also had the organizations like Mary Stopes who were able to like give online counseling, and then they were able to open their services 24 hours even though it was COVID. And people who seek services from these organizations had somehow been able to not have the unintended pregnancies. So talking statistically, we had about 163,000 of unsafe abortion averted in 2020. It was the data from the Mary Stopes International in Nepal. And also similarly, for the unintended pregnancy, Mary Stopes was able to stop about 264,000 of the unintended pregnancy in our country. So that is also a positive impact, let's say, of the COVID that we had. And also now moving on to the next question that Anika just posed for me, we had innovative approaches as well. So this was an opportunity for us to be digitally available everywhere. Our networks increase. So we have a lot of rural places as well in Nepal where there is no the people were not aware about this online and they were not digitally available. But this COVID made them mandatory to be available online, and from that we started up digital innovations as well. So so during this COVID we started telenursing, in which the uh, in which a group of the nurses formed a kind of counseling online, and they provided their phone numbers and they were available 24 hours, so that the ones who wanted to seek the counseling services, or they wanted to know anything about COVID or about any other health issues like related to the sexual and reproductive health, they were available. And this was done with collaboration with Yoshan. It is the one of the platforms that's working to promote the safe abortion, in which I'm also a youth champion. And in top of that, we youths gathered together and we were conducting sessions online to other young people whom we had contacts or from the other organization, like-minded organization working for SIHR. And we gave different sessions to them about this abortion, its political aspects, its other aspects as well. And also we started I think in Nepal there was a start of one of the political clinic that gave legal advices about the rights of the people related with the abortion or any other sexual and reproductive health and rights. So as I mentioned, the gender-based violence had increased a lot, and a lot of people were and the reasons were because the people were unaware about their legal rights. So the one who was the victim was also unaware about the rights, and the one who was initiating was also unaware about the punishments and all. So that's why the Nepal government started this clinic which is known as the law clinic, and it gave advices about the different kinds of rights, and people who wanted to seek help legally also could come here especially and report the gender-based violence. And it was also made available in all the 77 districts that we have in Nepal. Yeah. And these were some of the very major innovative approaches that we started. So I guess that's all from my side.
Thank you so much, Larisha. I think what we hear is really the need for information, the need for information, the need for information. So I'll move on to Jean-Claude, and of course I want to hear how, you know, how the COVID pandemic has affected rates also in DRC, but also to hear a little bit from how IPAS and other stakeholders can leverage the political support and leadership to really advance policy and legislative change that really can both protect the gains we've made, but also look at the current situation and the really increasing vulnerabilities. Over to you, Jean-Claude.
Thank you, Erika, for the question. As Larisha said, I think the COVID crisis affected all of us equally, but in terms of consequences, I think this is not the same. You know, the COVID situation did not have the same impact on all the regions in the world. It's depending also to the level of preparedness to this kind of situation. You know, many countries or region with high income was able to prepare themselves, which is really different from DRC, from my country, but also from many other countries in the world. The DRC, you know, we have the population which are poor, living less than $2 per day, and a health system which is almost depending to the external funding and sometimes depending to the contribution from patients. So we don't have, for example, in DRC, a reliable insurance system, or even the manufacturing of commodities. So all those things really shows that we were not prepared to face such a situation like the COVID situation. So when the COVID arrived, the COVID weakened our
Oops, maybe we lost connection here. Let's wait a little bit to see. Can you hear us, Jean-Claude?
I can hear you. Can you hear me?
Now we can. Now you're back. It was just a few seconds.
Thank you. So I was just saying that the COVID affected our health system, and as Larisha said, one of the issues was how people, especially women and girls, have access to the information. And yes, of course, we didn't have, for example, a lockdown for all the country. It was just some region, but it's affected people because, you know, people were fearing about being contaminated. So no one would like to go to the facilities where it's supposed that is the place that all those people contaminated with the COVID are going there. So one of issues was the no preparedness of the country to the situation, but also in the same time we had many other problems like Ebola. I think some of them of you were about Ebola in DRC. It was kind of shifting from Ebola to COVID. And also, as I was saying, we don't have a manufacturing of commodities in DRC, so we are depending to the commodities that are from other countries. So when you have lockdown in those countries, for example, or there is no possibility to travel, we have shortage of SRH commodities. And this, you know, even for women who were able to reach out to the facilities, they were not able to get services due to the shortage of the commodities. So what we did during the COVID, you know, to support women and to meet their need was, first of all, to, like as Laisha said, to try to work on the digital with social media, to communicate through social media and digital. One of the things that was interesting for us, especially for DRC, was that before the COVID, IPAS, in partnership with Experian, was working on the Experian app, which provides information on abortion and which can allow women to access to abortion safe use through the app. And what is interesting with that app is that it works offline. So when you have that on your smartphone, you can use that without, the need of the internet. So this app was really interesting because it helps women, especially youth, to have access to the services. But what we did during the COVID situation was to train the youth champions that can use the app not only for them, but could use the app for others, especially for those that do not dispose of the smartphone. So they use the app, which was designed before for individual use. They try not to use that as a tool of awareness activities in the community, because this was, easier for them to reach out around their region than going so far to look for services. So this was like one part of what we did. But the second thing is that, and I would like to recognize that the support was getting from UNFPA. UNFPA put in place kind of task force to continue supporting partners, as IPAS and others, to provide commodities, especially contraceptive commodities, so women can continue having access to the services. To come back to the abortion, and I would like
maybe also a little bit how you work on the political, leveraging political support together with partners. I think everyone is really interested.
Yeah. Thank you. So I think what we did is that from the work we started in DRC and as in many Francophone countries, we're still using the colonial penal code, which don't allow abortion, even contraception is not allowed for women. That allow women or expand the indication of the sexual reproduction right in DRC is the Maputo Protocol, which is from the African Union. So we started working on the Maputo Protocol before the COVID, and then we get some gain in terms of maintaining the momentum of the leadership. DRC is one of unstable country in terms of politics. So, things are changing every day, and leadership is also changing. The government is changing all the seats for 1 year. So this do not allow, for example, to maintain the momentum on the advocacy. So you need to restart every time you are advocacy. So what we did is to work on kind of national ownership with civil society organization, especially youth that were involved in campaign and in advocacy. But also we supported coalitions, local coalition in the country that advocate for access to the safe abortion. And this is what we did with civil society organizations, but we worked also with the government, especially the Minister of Health, the Minister of Gender. And within those ministries, we identified the champions, trained them, and continue working with them until now. And this allowed us, during the COVID, those champions with the civil society organization leaders to further how to work together and see how we can maintain the momentum of the government and leadership on the domestication Maputo Protocol as the way to prevent violence against women, but also to allow women to have access to the abortion. Thank you.
Thank you. Thank you so much. And I think here we're sort of collecting a number of things that are really crucial: the lack of information, the weak systems, the inequities, but also the new methodologies that need to be explored and expanded, and the importance of all partners in the partnership to push the agenda. So I turn to you, Valeria, and as a representative of the government of Argentina, I would really like to hear your view on what are some of the strategies that can be used to address unintended pregnancy for adolescents, and how you have, what your programs are and policies that you have used and developed in Argentina, and how you see this important issue of really maintaining SRHR services during this very difficult time. Thank you.
Tiempos difíciles.
Thank you. Regarding the SRH services during the pandemic in 2020 and 2021, as I mentioned before, of great importance was the declaration of the Ministry of Health. These services, access to modern contraceptive methods and access to voluntary and legal interruption of or termination of pregnancy, as well as the termination of pregnancies having three causes: risk for health, for life, and rape. And we added the voluntary termination till week 14 without reasons, plus the reasons that were already defined for other gestational ages. It's without limit. This was very important. We are a federal country. There's 24 jurisdictions, 24 provinces that in turn have local governments, municipalities, and the health system is within the remit of the provinces and some municipalities, and the National Ministry of Health, it has the oversight. It's responsible for very few health services. So in that sense, declaring this as an essential service was a tool for the teams in the provinces and us to be able to generate in the services established for the COVID the importance of SRH. Furthermore, in some provinces, we were able to, because they had stocks of contraceptive methods, so we could promote anticipated delivery of contraceptive methods, those short term, 3 months, and stimulate the insertion, particularly IDU and the some ones that are long duration. We're a very new country in the adoption of long-term contraceptive methods. So the pandemic left us in an unequal situation compared to other countries that already had a large population of young people and youth protected, young people and adults protected with the long-term protection method. Initially, we had problems with injectable products, but we formed a regional network, Orolac, and each country supported others. The other inputs, regarding them, we were able to maintain a sustainable supply. We purchased in the local market and also through the population fund, and we were able to maintain that in Argentina. We have supply free of charge. So the critical part were not so much the inputs themselves, including isoprostol for legal termination or voluntary termination later. We had a sufficient supply of that. But what was a critical issue were the services, the primary healthcare centers, the hospitals, getting them to have the services open with teams that could provide the services. This was one of the main pillars, particularly in 2020. Regarding, we also did a lot of work with the provinces in the area of stock controls to reallocate internally. Prior to the pandemic, we used to send sexual health kits to 5,500 healthcare centers throughout the country, in addition to the provincial sexual health areas to meet certain unsatisfied demand. And as I said, with misoprostol. So keeping the information about the centers updated so the population could access to the one closest to their home was a major challenge. In that sense, the 0800 telephone line that was available at a national level, that was already working because it was created about 10 years ago, was a very good tool. It's a free tool. You can call from any place in the country, and it helped to identify hurdles in access to methods and was the tool for legal termination of pregnancy because of those 5,500 healthcare centers where we send the kit for legal termination. We had teams in 550 centers, and in the case of more advanced pregnancy, there was an even smaller number. So, for example, we would hear about the problems through the free toll line, and we intervened with the health services and with the provinces to refer them individually. We had over 10,000 phone calls in all 2020. So that tool plus all the participative work on the network, the feminist participants in the different regions and provinces of the country. We had protected spaces online. So we had quick diagnosis of the bottlenecks, and then we directly intervene from the national governments to the health system in the provinces. This strategy was very successful for us. We guaranteed inputs, that is the macro public policy, but on the other hand, micro public policy. Our management team acted in each case, and that created better conditions and feasibility to remove the stumbling blocks. These were the two major lines with regard to the population at large. Additionally, we promoted virtual online meetings, digital prescriptions, uh, delivery and supply of emergency hormone therapy for emergency contraception without a prescription. That is something we have not achieved yet. We hope to have the approval by 2022 because we think that before and after the pandemic and during the pandemic too is very important. That on the one hand. And on the other, the virtual counseling. We have a national plan on unintended pregnancy in the jurisdictions of 12 provinces that include sexual health teams, comprehensive sexual education in the schools, and counseling on comprehensive health. These are advisors of the healthcare system that go to the school. The scaffolding was set up, it was in operation and had been for 2 years. When the pandemic started, we quickly were able to provide counseling online with Facebook and other networks. We had a lot of support from UNICEF to make this adaptation, but we know that the youth not going to the schools would have an impact. We don't know yet how much because official statistics indicate that we have figures for 2019 where we see a significant drop in teenage pregnancies, particularly between the ages 15 and 19, and a small decline for those under 15, and this is due to sexual violence, other structural problems. However, we still can't estimate the impact because we don't have the official figures, but also because there's a number of factors involved as well, the availability of methods and the laws that during the pandemic we had passed with the voluntary abortion in Argentina that was passed during the pandemic, and all the work we did with the teams and social protection programs in place, we really don't know what impact all that will have on the figures. We're anxious for in the coming months we'll be having them. So
Thank
then
you.
we have to see the recovery.
Yeah, thank you. We will be very
will
much looking forward to also knowing what the impact will be. I will now, it's so interesting and time flies, but turning now back to Beth also, because you've been listening here to the different examples from different countries and different experience with different situations. So from your global perspective, have you seen other kinds of innovative approaches or adaptations that you think would be important to really mention here, but also maybe talk a little bit about the success factors that you know are needed to change that trajectory that you showed in the beginning? Improvement, but too slow.
Thanks. That's a great question. And I think the last part in particular, a challenging one to tackle, but I think maybe together with the other panelists, we'll cover enough of it collectively. I think I wanted to start by maybe mentioning that we've seen, when we looked at the data across countries on impact, we're starting, because it took a while, like we started doing some hypothetical modeling early on, and we're really concerned about the potential impact the pandemic could have, looking at prior public health emergencies, looking at the potential scale of disruptions and services we might see. And we were sort of ringing the alarm bell saying, we have to, UNFPA everyone was saying, this is really important. And I think when we've started to see the data come in, and really it's just for 2020, we haven't even seen what's happened in 2021 yet. And we're not through this pandemic, it's still ongoing. But we've seen a lot of range of different experiences. So we just released a report of adolescents' access to contraceptive services in 2020 in Uganda. And we found there was an early dip, right, in April of 2020, but it actually increased back to regular levels. And in the end, they actually ended up having more services in 2020 than they had the prior year. And so there was this sort of success story. And I think that's where we have to start to look at what were the things that governments have done? What were the actions taken by NGO providers and other actors in private sector that ensured that these services were maintained? And I think some of this cross-country comparison work is going to be really informative, as I think we're going to start to see a lot more data coming out in the coming months and year, and to really learn from that and measure those successes. On the other hand, we looked in Ethiopia, and in Ethiopia, we actually found a 3.5% decline in adolescents' use of modern contraceptive services, and estimated that resulted in just close to 9,000 additional unintended pregnancies. And so it's a very different story, two countries in the same region. And I think we need to start digging into this and understanding it better. But the pandemic it's also provided an opportunity for us to think about where are SRHR services being treated differently? Where are we exceptionalizing them? And where are they not being seen as essential, routine, and normal? And I think there's a number of things some of the other panelists have touched on that have brought that up, of places where, we have additional requirements for access to misoprostol or mifepristone in countries where access to contraceptive pills are more difficult to get from pharmacies than other types of medicines. And there's no scientific or medical reason for that differential access. And so I think it's almost like the pandemic can provide us a lens right now to reflect on our regulatory regimes, on our supply chains, on our sort of standards and provision of care, and say, where do we treat SRH differently and why? And is there a real scientific reason for that? And if not, then let's change that. And this is sort of an opportunity for us to do that, because we are reflecting on how to provide these services better in emergency times. That was just sort of from a global perspective, and things I was thinking, listening to some of the comments coming out from other panelists right now.
Thank you. And I think very important that we are, there is not one picture that is true. There are so many different pictures. And of course, the quality of data and the quality of analysis of data and all of that is also important. So I would like to come back to all the panelists for a short second round, and then we'll turn to the audience questions. And I would like to remind the audience to post your questions, and let me now repeat the address again. You send your questions to mhi@wilsoncenter.org, mhi@wilsoncenter.org, and we'll try to make sure that your question is responded to. Now, the question I would like to come back to all of you is to, if you could sort of condense what you think will be really important success factors in your country, in the environment where you are working, to really make sure that we don't lose what we have gained in SRHR, and also, looking at how can we actually increase the resilience of systems and young people's role and how they are accessing the services that they need. So if I turn to you, Larisha, what do you think from your perspective as a young SRHR advocate and worker, really? What are the success factors that, and they can come from, it doesn't have to be you providing them, but what are the success factors that you see need to happen?
Yes, so this is a very important question, I think, and it's a very weighty question as well. And I find it really difficult to just answer it in one sentence. But I also think that, as you mentioned, it cannot be just me, because I myself just cannot go on advocating and then solving this problem to be successful. And I think that there is one of the most important part is that we have to work intersectorally. So it's an issue that just one person or just one organization cannot solve it, or it cannot help it to be more successful. So I think there is a need of a collaboration from each and every sector, like not just the health that is working on this, but also from the education sector, from maybe the infrastructural sector. So in that way, if we collaborate together and work, then only we can address this issue. And the most important thing now, particularly if I have to talk about my country and my country, Nepal, then I'd say that the most need is to reduce the stigma that is associated with the sexual and reproductive health and rights related topics. So the society needs to normalize, especially now we have to work with the intergenerational as well. So if we start working in that way, then we can also work together with the older generation as well as the younger generation that is yet to come, and then make it comprehensive, so that we will be able, now the present youths who are working on this would be able to successfully advocate for the issues and bring about some changes. And also I think we have to also think about how we can digitalize more. So this tele-nursing, telemedicine concept has just arrived in Nepal, and I think we can still work on it to make it a success.
Thank you so much. I'll move on to Jean-Claude. Success factors, what are they in your mind?
Yeah, thank you. I think this is a critical component, because we really need to protect the pre-pandemic gain. And for DRC, for example, how we work was related to the mitigation protocol, which allow women to get access to the abortion. So one of the gains that we wanted to protect and move forward after the pandemic was in the advocacy level. And one of the things that we did, to be sure that we protect these gains is to invest in not only in the community engagement, but in the national ownership. So on all the level, from the leadership to the bottom, everyone have to have access to the information, but also we cultivate all the category of people of leadership, to the women's right, supporting them with training. And this was really easier for us because IPAS developed an abortion ecosystem, which is a tool that allowed us to understand not only women's need, but also the environment around the woman. And in this environment, you have political matters, you have also social norm, you have the health system with all the issues that I described here. So we worked to address using that, and that allowed us during the COVID, for example. Yes, COVID affected sexual reproductive rights, in many countries. But in DRC, for example, it allowed us to have to accelerate the process of drafting and validating of standard guidelines for compulsory abortion care. Because as Lirisha said, the number of DBV cases increased. So that also drives to the increase of the unintended pregnancy. So many organizations which are working on the women's rights were forced to include in their package the possibility for women to have access to the abortion. And if you look at the Maputo Protocol, it's based on the DBV case. So this, with all the leadership support that we had and the need from the ground, allowed us, to work with the government, the Ministry of Health and Minister of Gender, to have the standard guideline validated. And right now, abortion is legal for the case, which is recognized in Maputo Protocol. Thank you.
Thank you. So you're talking about both success factors that address the structural level as well as the individual level. I hear that. So Valeria, I always listen to stories from Argentina and your development, and it sounds very easy when you talk about it. And I know it's not easy, but the way that the whole development has happened, what were the success factors? How, to move it as far as you have been able to move it?
Bueno,
Well,
por un lado,
on the one hand, a very important factor was activism, feminism in Argentina, and the development of organizations and feminist networks and organizations. As you know, as of 2015, the Ni Una Menos or Not One Woman Less movement, there was a green tide that took to the streets, and that created a process that catalyzed and unified campaigners, 90-year-old campaigners like Nelly Minchaski, who is 92-year-old today, to 11-year-olds, teenagers who would fight in the streets for comprehensive sexuality education in schools. So I think that first, being able to uphold and recognize that public policy in Argentina in terms of sex and reproductive health, which was installed 20 years ago because the law was passed many years ago, but the state policy, the public policy, has been and is a great contribution and puts this on the agenda of civil society. And today, the public administration implies that the design of any strategy has to consider this in all of its diversity, and considering the diversity of Argentina, because in the provinces, there is great inequality in access to health. So that's on the one hand. On the other hand, as part of these processes, we consolidated a budget for sexual health, which guarantees the purchase and distribution of supplies from the federal government to the provincial health centers. A diverse supply of 11 products in our portfolio that we added gradually, and we plan to continue increasing this availability, and also the design of federal programs, such as the National Unintended Pregnancy Program, where we reach out to the territories where these adolescents live, in schools, in the neighborhoods, because teenagers generally do not go to the health centers. So we have to create mechanisms to reach out to them across sectors and across disciplines to reach out to teenagers. We are developing an application of virtual counseling, and we hope to have it ready next year. And we also think that a big challenge is also being able to carry out a massive communication campaign. In addition to strengthening the supply of health services and these mechanisms after these 2 years of pandemic, it is very important to raise awareness and to encourage people and to communicate and to strengthen the demand from young people, from collectives of diversity in Argentina, such as trans feminisms that have made an enormous contribution, and all the laws of the diversity collectives, and they have contributed to the achievements in reproductive health. Another big challenge is to prioritize the collectives of people with disabilities and sexual and reproductive health and rights. We have Aboriginal leaders, women leaders, with whom we are working in the interpretation and in making services and materials more available. So we think that we have big challenges ahead, and we hope that we will, based on our shared experiences, we hope that we will have the tools to resume our cover levels before the pandemic so that the population can access health services. That's our biggest challenge. And we have to continue working together with the civil society organizations. And we have to understand that working with the civil society organizations, feminist and trans-feminist movements, implies accepting complexity, but also diversity. We must not try to unify everyone. I think that these microdynamics of the territories, organizations, feminisms, activist movements, and the cooperation agencies, if we can respect that diversity, we will be able to create a sexual health agenda with the greatest impact and a more comprehensive one. Thank you very much.
Thank you so much. And I think you really touched upon some very important pieces that also the others mentioned. It's really about ownership, but not only ownership generally, but ownership by everyone and reaching everyone, making it accessible, available. And it seems like no challenge is too big for you to take on, even if you don't see the solution, you don't hesitate, even if the challenges are there. I think it looks like the Argentine government really takes that one. So Beth, any reflections from your side on success stories more than you've already talked about?
I mean, it's hard to think about what to add because I think everyone's touched on, from innovative service delivery models and education, communication, activism, advocacy, government support, and how SRH is being provided and supply chains. I think we've touched on so much of it. I was just thinking the only other piece to maybe think about is the role of integrating SRH within the health systems, and that there's this lens being put on the strengths and weaknesses of our health systems right now, because those have really been brought to the forefront in seeing how countries have been able to manage the pandemic. And I think that there's going to be a lot of attention focused on health systems going forward. And so thinking about how SRH is integrated into the health system, how treating it as an essential service, how it's really should be part of packages of universal healthcare. These are some of, I think, the avenues going forward and lenses to sort of capitalize in some ways on the COVID moment to make sure that SRH is being part of the conversation and being invested in continuing onwards.
Thank you. Thank you so much for this discussion. Now I have a number of questions from the audience that I will read, and we'll do it as this, that if you feel like you would like to respond to that, you just unmute yourself and I'll see the little yellow square around your image. Did you lose us, Valeria? Did you hear? Yes. So I'll start with one question that is like this. How can programs and policies ensure that people of all gender identities are able to access sexual and reproductive health services? So it's really about reaching everyone. And how have you seen that SRH care has changed during the pandemic for these groups? Have you had any experience of that? Don't know who would like to talk about that. Do you have any experience of really reaching those maybe most marginalized all gender identities? You talked a lot, Valeria, about reaching, the furthest behind. Is this something also in Argentina that you have put attention to?
Sí, quería
Yes.
compartir.
I would like to share with you saying that the cooperation, particularly as part of the National Plan to Prevent Unintended Pregnancy, we worked with education on comprehensive sexual education, but also with social development, all the area of children and youth, populations with extreme right violations. And this has to do with the cooperation, counseling, and workshops in the more vulnerable communities, the networks to protect the rights in all the areas of girls, forced pregnancies, forced maternity. We worked with different levels of favorable results. In Argentina, the different ways they work in the provinces is very different, but we worked with social development units that are work in settlements in what we call the popular sectors of Argentina. We addressed that, yes, and we also innovated with some digital options which are not so accessible in Argentina. The use of the mobile phone is widely spread. So some networks, TikTok, Facebook, have also enabled access.
Thank you. Thank you so much. So the next question is about the role that the United States government can play. So the question is, what do you see as the role of the US government in protecting access to SRH services through global health programs and foreign assistance? I'm not sure who would be, I don't know, Beth, if you would like to take that on. Or
Yeah.
Jean-Claude opened his, please.
Good, Jean-Claude first, and then I'll go.
Go ahead. Go ahead, Jean-Claude. I'm
Beth.
happy that I didn't want to put anyone on the spot on this particular.
Thank you so much. I think I would like to use the example of DRC. You know, many organizations lost their funding from the US government due to the gag rule. And some of them, like even on the ground, you know, organizations are fearing about providing some services like abortion services, even if it's the need for women on the ground, because they are like receiving US government funding. So it's not only the impact on the fact that the funding that could help women is not coming, but also it's the fact that they prevent providing services for those who are benefiting from their funding. And this is like impacting the life of the women on the ground in the country with low income like DRC. So what I can say here is that this kind of decision of law impact the woman's life. In our country, we need more actors. DRC is a big country and the government is struggling with many problems. So as I said before, the health system is depending to external funding. So when the US government not only prevent using their funding to support sexual reproductive rights, especially abortion, and then do not allow those who are benefiting from that funding to provide services, is a big gap on the ground. Thank you.
I think the question was also, how can they actually support more? So what you're saying is that because of certain policy implications, it's difficult for them to support. But I also know that there is support to other parts of SRH. Maybe Beth, you would like to pick up to see.
Yeah, I would just say, like, the US, especially when it comes to family planning funding, is one of the most important donors that's out there in terms of just the amount of money, which is why with the global gag rule and policies, the scale of that impact can be so large. But for example, in fiscal year 2021, the US gave $607.5 million for family planning through their global health assistance program. And we did estimates that actually ended up preventing 12 million unintended pregnancies through that funding in that year. And I think that recognizing that that's a starting point, but the fair share that the US can play is greater than that. And that aid needs to come without the conditionalities like the global gag rule. And there's opportunities like the Women's Health Promotion Act that's in front of Congress for there to be legislation to really support women's health going forward. And I think we also have to look at not just the role that the US can play, but other countries that are out there, that we are seeing big changes in aid funding as a result of the pandemic. There were large cuts from FCDO in the the UK. And the impact of those cuts are estimated to be incredibly large. And so I think it's this moment where we need to look not just at the US, but across all of the donors that are essential to the SRH funding environment right now, and to really call attention to changes in that funding to ensure that this is not a moment for cuts, but a moment for increases in funding, because things are going to cost more, and we can't, as we've been talking about this whole time, we can't afford to slide back.
Thank you. And we do also see like the new gender strategy of the US really showing a move towards a more progressive stance in these areas. But thank you for both of your perspectives, really important. And I think it's really not, as you said, just the US, it's really all donor countries that need to keep the attention up. Let's see, we have another question here. Larusha mentioned GBV significantly increasing unintended pregnancies. And of course, we know that it's been exacerbated widely through COVID and during the pandemic. Has this also been found in Argentina and DRC? Or has Guzman found evidence that sexual violence and forced early marriage have significantly affected the overall numbers? So maybe I'll start, I don't know who wants to start. What have you seen on the GBV side in Argentina, Valeria? Have you seen rising figures due to the pandemic on that? Yes, please go ahead, Valeria.
Gracias. Sí.
Thank you.
Sí, nosotros hemos visto.
Yes, we saw an increase in gender-based violence. We have a ministry that was established in late 2019 by the current president, Mr. Alberto Fernandez, the Ministry of Women, Gender and Diversity, and they have a toll-free line 144 that receives the reports, and we have had an increase, and we haven't been able to reduce the number of femicides and trans-femicides reported in Argentina. As to girls and teenagers, we, with the 0800 line and the referral from the gender-based violence line, we've managed to give visibility and see the increase in the number of calls and interventions of the protection system. Also, forced pregnancies, access to termination of pregnancy. We still don't have official statistics, but we're in line with what's been happening in the region.
Maybe,
and
yes,
if you
sir.
allow me, regarding the previous question, in addition to what the colleague said, I think the support to feminist organizations in the countries also has an impact. In the US, there are some that are very important, and they have an impact in all countries of the world. And also, seeing the issue of prices, the monopolies of contraceptives in general, would be interesting to open the agenda to discuss these issues.
Thank you. Thank you so much. I was just thinking, Larusha, you were the one who brought up the gender-based violence, and there was something you mentioned in the beginning. You said that due to the pandemic, the men stayed in Nepal. And of course, it increased unintended pregnancies. Did you also see that rise in GBV due to that? Or do you think, what were the reasons? What are the reasons as you see it from what you've heard in Nepal?
Yeah, so yes, most of the now evident cases were of the rape that was in the newspaper, in the media, everything that was saying that the rape cases increased, especially in the rural areas where now the as the lockdown started, there were school dropouts of especially the girls, and then they were forced to do child marriage, and then they had to do the child marriage, and after going to their married house, they were forced to have unintended pregnancies. They had this unwanted sexual contact as well from their husbands as well, I guess. And they could not also voice back because they had no option to go back also, because the society does not accept them like that. So that was also one of the major reasons. And yes, I think the main increment of the unintended pregnancy was also because all the people, as I mentioned before as well, the ones who were going abroad for work, the migrant workers and the workers who were going out, they all came back to Nepal to their own families. And maybe there was some kind of more increase of the unintended pregnancies because they did not had access to the contraceptives, and since they were locked down in their own home with their own wives, however, that also may be one of the reasons that these increased, because now they were with their family, they were with their wives, and they just had the sexual contact, because that does not stop. So even in time of COVID, so maybe that was one of the major reason as well, I think, if I answered your question.
Yes, okay, that's fine. I just wanted to give Jean-Claude the last opportunity to also talk about the situation on GBV in DRC during the pandemic. Any reflections from your side?
Yeah, thank you so much. I think for DRC, and it's known that from, take a DRC in how eastern part of the country, we are facing the war. And then in that kind of humanitarian setting, there are many cases of GBV, which is, always identified. But with the COVID situation, the number of COVID is it not only in that humanitarian setting, but also in the rest of the main part of the country. And this, we have like a call center where women can call, to get information about GBV, and this call reported the increase of the number of people that are calling to get information. And one of the things that we've seen during the COVID was that women was not calling only for the GBV, but also for some other reproductive health issues. Okay. And then through our advocacy, we worked with the government to include in the package other information like abortion information in that national call center. So it's like the same situation like in many countries.
I think we see that across. Unfortunately, we only have 3 minutes left, and this means that I need to wrap up. I would like, from the bottom of my heart and from my SRHR soul, thank you all for your very rich discussion and answer to the questions. I'm sure there are many more questions out there, but I just wanted to say that this event is being recorded and will be available also on the Wilson Center event page by the end of the day or tomorrow morning latest. And there will also be a summary of today's event available on the .mom column of our blog, New Security Beat. And with that, I just want us to feel very inspired by all of you to take the next challenge on. And we really want to carry this torch that no unintended pregnancy, no unsafe abortion should have to happen to anyone. Thank you for being with us today.